Fun.
Right, we're live.
All right, everyone, welcome back. 10:15 on Thursday, May 7th. We are picking up some witness testimony, piggybacking off of yesterday's robust discussion on S64, an act relating to amendments to the scope of practice for optometrists. And we are joined by Kelsey George, Senior Policy Specialist, Health Program, and CSL. How are you?
I'm doing well. Thank you for having me.
Cool. Table is yours.
Fantastic. I will share my slides. Can you see
Yes. Yep.
the presentation? Fantastic. Well, thank you so much, Chair, and thank you, committee members, for having me. Again, my name is Kelsey George. I'm a Senior Policy Specialist with the National Conference of State Legislatures, and I'm here to provide testimony on Senate Bill 64 and to provide an overview of state regulations of optometrist scope of practice. So a quick roadmap of my remarks today. I'll provide a brief introduction of NCSL. I'll provide a short overview of optometrist licensure and certification requirements across states. And then I'll dive into a variation of state optometrist scope of practice laws and regulations across ophthalmic procedures, prescriptive authority, and injectable authority. And I'll close with a few additional resources. Now, this is a lot of information to cover in 15 minutes, so I kindly request that you save your questions for the end of my presentation. I'm more than happy to send information after today's presentation if you have follow-up questions. So as legislators and legislative staff, NCSL is your membership organization. We serve our members in a variety of ways, as you can see on the slide here, including policy research and testimony, as I'm providing now, hosting convenings to facilitate shared and collective learning, like our legislative summit, which is coming up in Chicago in July. And while I'm based in Denver, Colorado, we also have colleagues based in DC who advocate on behalf of states to the federal government. We also have a myriad of legislative databases, publications, podcasts, webinars, all publicly available on our website, which will be linked throughout my presentation. So an important note, NCSL staff, like myself, are nonpartisan, and we do not take position for or against any state policy. So all of the information I'm sharing today will provide a snapshot of what trends and recent actions we're seeing across states and does not indicate support or opposition for Senate Bill 64. First, I want to note that health policy is consistently a priority across state legislatures. NCSL created this graphic based on the requests that we received from members like you, and this is a reflection of the types of questions that we received from legislators and legislative staff in 2025. No surprise, Medicaid is a well-established focus within state health policy, as it's a huge part of state budgets. Workforce issues are also front and center. Affordability and access remain hot topics as well, especially when it comes to commercial insurance, prescription drug access, affordability, and health system concentration. And states are focusing on things like maternal and child health, behavioral health, among other issues as well. NCSL maintains a database that tracks, we maintain about 50 databases across a variety of policy topics. This one in particular tracks enacted health workforce legislation across all 50 states, DC, and the territories. And it includes bills from 2024 through present and is updated biweekly. This slide shows a quick snapshot of the trends in enacted workforce bills that we've seen so far this year. These trends are consistent, albeit with a higher total number of bills so far this year than we've seen in the last 2 years. So at least 41 states and DC have enacted at least 348 bills addressing health workforce topics so far this year. You can see several professions noted on this slide. No surprise to you all, I'm sure, behavioral health, primary care, nursing, and long-term care are significant topics across states. I'll note the other professionals category here is also quite large. That includes allied health occupations and other healthcare occupations, including eye care professionals like opticians and optometrists. We saw at least 21 bills enacted across 15 states so far this year on optometrists alone. And these touch on topics like scope of practice, like prescriptive and vaccine authority, licensure and certification, like continuing education requirements or professional liability insurance requirements, and workforce protections like workers' compensation and regulation of non-compete agreements. So before I jump into how states regulate optometrists specifically, I want to note that these professionals exist within a system of several eye care occupations. Opticians primarily fit customers for lenses prescribed by optometrists or ophthalmologists. Ophthalmologists are physicians specializing in eye care and are generally trained to provide surgical and other procedures. And opticians fall in the middle here. They're required in every state to have a doctor of optometry degree and generally diagnose, manage, and treat eye and vision-related conditions. So every state sets licensure requirements for optometrists, though they vary greatly in the education and training requirements, examination requirements, continuing education for licensure renewal, and other requirements such as age, U.S. citizenship, English language proficiency, liability insurance requirements, or good moral character requirements. Now, I'll touch on these in more detail, but to my knowledge, no states license multiple levels of practice for optometry, though they may require certification to perform certain primary eye care procedures like surgical or laser privileges, to prescribe medications, or to treat certain conditions like glaucoma. So the Association of Schools and Colleges of Optometry reports that there are at least 25 optometry schools across 16 states. Upon completing the didactic or classroom education requirements of a Doctor of Optometry or OD degree, graduates may complete clinical residency training to specialize in their particular categories or emphasis areas within optometry listed on the slide here. Residencies generally include specific hours of supervised clinical experience addressing these emphasis areas, like providing pediatric care, diagnosing or treating glaucoma, or focusing on vision and rehabilitation therapy. In addition to the degree requirements of a Doctor of Optometry degree, states may define hour requirements for didactic and classroom education, or they may define clinical training requirements that applicants must complete in order to achieve licensure. So there are a lot of examples listed on the slide here. Additional hour requirements, when they're outlined in statute or administrative code, generally range from 10 hours in California to 1,000 hours in Delaware. And they may include both didactic and classroom education and/or supervised clinical experience. Some states, like Arkansas, California, and Hawaii, specify that supervised experience must be under the supervision of a licensed ophthalmologist, while other states may just state the supervision requirement broadly. States also set the examination requirements required for licensure within the state. So examinations are used to determine an optometrist licensee applicant competency and are generally administered by the National Board of Examiners in Optometry. Nearly every state requires NBEO Part 1, 2, and 3, which cover applied basic science, patient assessment and management, and patient encounters and performance skills. According to NBEO also offers examinations in additional areas of optometrist care. Those are shown in the middle of the slide here, which include treatment and management of ocular disease, injection skills, laser and surgical procedures, and advanced competence in medical optometry. Some states may require these additional examinations, like Alaska and Louisiana, which require injection skills examination for licensure. Oklahoma requires licensed optometrists to complete laser therapy for anterior segment course that is offered through the Northeastern State University prior to taking examinations. At least 40 states and Washington, D.C., including Vermont, require the treatment and management of ocular disease examination for optometrist licensure. And many states also require licensees to pass a jurisprudence examination, which is basically assessing their understanding of laws and regulations of their profession in that state. Every state also sets continuing education requirements for optometrists, but this may vary in the number of hours they must complete, the topics they must cover, and the licensure cycle they must complete it within. Vermont statute currently sets general requirement for continuing education at 40 hours every 2 years. Some states like Alaska, Florida, Rhode Island, and Mississippi require continuing education hours on pathology, pharmacology, or controlled substances. Mississippi requires at least 6 hours of continuing education every 2 years on primary eye care procedures, including authorized surgical and laser procedures. And Pennsylvania includes a course every 2 years on child abuse recognition and reporting. Now, in addition to our health workforce legislation database, NCSL maintains a scope of practice policy resource center, which includes 50 state, DC, and territory information on scope of practice regulations for a variety of occupations. Some of those are captured on the slide here, like licensed professional counselors, nurse midwives, nurse practitioners. We also include information on optometrists. So the maps that I'll show shortly come from this resource. And one note that I'll make here is that there's a variety of research on the outcomes of state changes to optometrist scope of practice. There are several studies that find optometrist surgical, laser, injection, and prescriptive authority may expand access to primary eye care services, while other studies find no change after states made some of these changes to these activities. I'm happy to provide links and summaries to these studies after today's meeting if that would be of interest to you all. So the first area of scope of practice that I'll touch on is optometrist authority to provide ophthalmic procedures. This may include things like surgical procedures, removal of lumps and bumps, certain diagnostic testing, and other procedures as shown on the right side of this slide. So several states allow optometrists to perform additional procedures. At least 13 states allow surgical or laser privileges. At least 8 states allow the removal of lumps and bumps. And at least 4 states allow other procedures, like those diagnostic or blood testing, certain therapies, or foreign body removal. I want to note that this map may look, and the other 2 maps may look slightly different from the handout that was distributed. That handout reflects what is currently on NCSL Scope of Practice Policy website. I was able to update some of these state information yesterday. So the maps on my slides are the most accurate, and I will make sure to get you all a copy of those as well. The second area of optometrist scope of practice that states regulate is prescription of controlled substances. This may include Schedule II drugs, which are labeled as having a high potential for abuse and severe dependence. Typically, when states allow Schedule II prescription, they are limited to hydrocodone or hydrocodone combination drugs like Vicodin. Connecticut, Idaho, Iowa, Louisiana, Mississippi, and a few other states allow any Schedule II through 5 drug. Schedule 3 through 5 drugs are considered moderate, low, or lower potential for abuse and severe dependence. Hawaii, Maryland, New York, and DC do not grant optometrists any prescriptive authority, while Indiana and Minnesota allow optometrists to prescribe Schedule 4 and 5 drugs. Vermont statute currently allows optometrists to prescribe Schedule 3 through 5 controlled substances. And Senate Bill 64 would allow optometrists to prescribe or administer hydrocodone in combination with other prescriptions for up to 72 hours and with no refills. Other states also set limits on the duration and refill authority of prescriptions by optometrists for Schedule 1 through 3 drugs. For example, Alabama sets this at 96 hours, and there are several other states that set it at 72 hours, like the proposed bill. According to the Knee Regulatory Research Center at West Virginia University, almost every state that allows hydrocodone only Schedule 3 prescribing requires licensees to complete those parts 1, 2, and 3 examinations, as well as the TMAD examinations for licensure that focus on those therapeutic pharmaceuticals. Arkansas, California, and Colorado require clinical experience or training hours under the supervision of an ophthalmologist and also allow that prescriptive authority. Several states offer certification for licensed optometrists to prescribe or administer therapeutic pharmaceutical agents. To my knowledge, these states require certification for all new licensure applicants, or they waive this requirement because the additional education or training requirements have since been incorporated into optometry education programs. So beyond the classification of drugs, states may also set certain restrictions on the types of medication that an optometrist may prescribe or administer. These generally fall under pharmaceutical therapeutics that are administered topically, orally, or via injection. Topical medications generally include eye drops, but may allow the prescription of antiviral medications to treat certain eye or visual conditions in conjunction with other members of a patient's medical team. Optometrists can generally prescribe oral medications. At least 44 states allow optometrists to administer or prescribe oral steroid medications. And moving on to the last area of scope of practice, among states that authorize injection authority for optometrists, some may also define the specific, I jumped ahead. In most states that allow injectable authority for optometrists, they fall under a general authority. But in addition to this, states may also define the specific injection procedures or activities that optometrists are allowed to perform. As you can see on the map here, states in blue may allow optometrists to administer injections to treat anaphylaxis only, like epinephrine, while states in this green or teal color may administer injections more broadly. So among states that authorize injection authority for optometrists, some may also define the specific procedures or activities they're authorized to provide. Existing Vermont statute authorizes optometrists to administer epinephrine for the treatment of anaphylaxis, while Vermont's Senate Bill 64 proposed bill lists several different types of injection authority that optometrists would be authorized to provide, including vaccinations under certain circumstances, angiography, local anesthesia, removal of certain lumps and bumps, and therapeutic and pharmaceutical agents. This chart shows several other states that outline specific injection procedures or activities in statute. I want to note that this list isn't exhaustive, it's just a smattering of state examples across the country. So not all states explicitly grant authority for optometrists to administer vaccinations or conduct angiography. Some states note the removal and treatment of chalazion or a sty or a bump on the edge of the eyelid. And some states specifically note Botox, which I've included under therapeutic pharmaceutical agents in this particular table, like Minnesota specifically notes Botox under injectable authority. Some states also note needle drainage, which is not included in the Vermont bill to my knowledge. Mississippi is an example of this, as well as Tennessee. So with that, I've included some additional resources here for your reference. And I want to thank you again for inviting me to present. Thank you so much, Chair and committee members, for having me.
Thank you. Questions for our guests from the table? Rep Stone, then I got Rep Nugent.
Hi, I was wondering when you looked into some of the education requirements and programming for each state, if you parsed out like which states incorporated the hands-on training with surgical procedures into their OD programs. Because I heard you say there's 16 states that have optometry schools, and I was wondering if you looked into the specific program makeup of those schools.
Thank you. I did not look at the specific education requirements of education programs. The purview of my presentation is really to present state legislative and administrative rule regulations, though I'm sure someone from the Association of Colleges of Optometry would be able to provide a more in-depth analysis of what is actually covered in each of those 16 programs.
Revolution.
I was wondering if you had any sense of or understanding of what the malpractice laws are in all the states where this expanded scope has been in place. My understanding is Vermont's bar is pretty high to succeed with that, and so I'm just thinking about the accountability factors and where the pressures are, and if it's the right level in Vermont and how that compares to other states.
Thank you for your question. I am not familiar with the malpractice insurance requirements of each state, though we do have other staff at NCSL that track that across all 50 states, and I'm happy to provide that information for you in more detail.
I think we might have some of the answers to that question from our witness yesterday. Who was sitting behind you in the gallery. We got some handouts.
Is it
No, I think it was
This one?
electronic, on malpractice insurance. Sorry,
okay.
it was. Yes.
That one?
Thank you.
I think it was posted online.
Yes,
Okay.
thank you very much. Under Emma Schuldeis's name.
Any other questions from audience from NCSL for the moment? You? All right. Thank you so much for that. As always, you all at your organization are a wonderful resource for us. I want to thank you.
Thank you so much for having me.
And up next, Tina Ksheva, President Optometrists Association. Thank you for your patience and spilling over into today's testimony from yesterday.
I will send all of the journal articles and anything I refer to during my speak right now later, but I will hold up what it looks like so you'll know what to look for in your emails. So. Good morning, Chair Barong and members of this committee. My name is Tina Keshava. I'm an optometrist in Rutland and currently the president of the Vermont Optometric Association. Thank you very much for allowing me to speak today on the need for scope expansion of optometry in Vermont. Not only are current optometrists trained and educated to perform these procedures, but it's also safe and effective when they do. Modernizing optometric care in Vermont will also improve access while reducing costs for your constituents who are our patients. Optometry as a profession has progressed over the past century, expanding scope to dilating patients in the early 80s and to treating eye diseases like glaucoma and uveitis in the early 2000s by increasing our prescribing authority. This 2023 article by Bay, Timmons, and Nandy shows that there was an average 12% reduction in visual impairment in the 15 years following the last scope expansion. So that was when we were able to start treating with oral medicines and more eye drops. Another 2025 study by Bay and Salud, looks like this one, examined laser scope expansion and showed that improved access was noted in rural areas more than urban, and that greater benefits were seen in earlier adopting states than later ones. Likely because it takes a while for the doctors to get up and running and get used to doing these procedures, and also because it just takes a little while for the benefits to show. And this gives us another reason why we should pass the bill now so we can kind of start the ball rolling. Our education evolved before those changes were enacted, and it is time again for our scope to match what optometry graduates are trained to do. As you heard from Doctors Feist and Lighthizer yesterday, these student doctors are getting close to 10,000 hours of education and 2,000 patient encounters before they graduate. With scope expansion, patients will be able to have greater continuity of care with their local eye doctor and save on extra transportation, time, and unnecessary copays because they won't have to be referred out all the time. And because this bill will give optometrists more tools in their tool belt to treat these common conditions. I would like to demonstrate how this works by introducing you to Dr. Dan Phillips from St. Albans, who unfortunately could not be here today. It's oh, he did. Sorry, what happened to my page? But in any case, so Dr. Phillips would say he sees a patient and he determines that they need selective laser trabeculoplasty or SLT, which is the laser that's used to treat early glaucoma. And he decides they need it. He would refer to an ophthalmologist. So he has an ophthalmologist above his office in St. Albans. Unfortunately, the wait time to get in to see him is too long. So he refers out to Burlington. So then this patient and maybe their caregiver or driver needs to drive 45 minutes to repeat the exam that Dr. Phillips already did, 45 minutes home, and then another 45 minutes to get treated for each eye, so 2 more trips at least. And if Dr. Phillips, who was able to do this last year in Oklahoma, could treat him, it would have saved all of that extra time, all that delay in waiting to see the doctor. So it just saved a lot of money and time, basically, for the patient. Dr. Phillips is excited for this bill to pass, but like Senator Morley mentioned yesterday, not every optometrist is actually going to go ahead and get this extra license or advanced license. At our most recent optometry meeting, I asked the room full of doctors, how many of you are going to get this advanced procedure license? And about 25% or so of the doctors in the room raised their hand. And Dr. Lighthizer, speaking with him, he seems to think that it's closer to 15 to 20% of optometrists in any given state will go forth and do the extra hoops and extra training for this procedure. So, but even 15 to 20% more providers in our state that are able to do these procedures, I do believe would make a difference. And let's see here. All right. So I'd also like to address concerns regarding complication management. Most of the common complications from these procedures are already managed by optometrists in their office. And when they can't handle it, they refer out to appropriate specialists. In states where optometrists perform these procedures, complication rates are very low and comparable to ophthalmology. In fact, that's what happened. In this study, Dr. Ligthizer's study that came out in 2024 showed that of 146,000 patients that had laser procedures done by optometrists, there were only 2 negative outcomes, which is pretty good, I think, and very comparable to ophthalmology. And then he also highlighted this new study that came out last month. And that was what showed that malpractice rates did not increase for optometry procedure, laser procedures, which is why our rates are still really low. And as Representative Ango had mentioned, we received this yesterday, and this is just showing that over the years from 2011 to 2024, that the rates really haven't gone up. And some of the states that scope has changed, such as Colorado, you can see that it fairly went up over time, and really inflation can explain a lot of it. There is some variation between the different states, but the variation, some of the higher states don't even have the scope expansion. I also think that this is why no scope expansion of optometry has ever been reversed. That's been approved in the past. We have also heard concerns that optometrists do not take call. When I recently surveyed 10 optometrists across the state, of the 7 that responded, 5 had 24/7 call, 1 had 24-hour care for high-risk patients, and 1 said that they would extend their call if they started doing these procedures. Next, let's talk access. Access to routine eye care is a problem across the state. Wait times for new patients' exams vary greatly, with some optometrists getting them in within a few weeks and many taking 6 months or more. When we see someone that needs one of the treatments from this bill, wait times to get into an ophthalmologist vary as well, depending on what they need and where they live. This delays their care even further. In Chittenden County, which is one of the highest concentrations of the 33 or so ophthalmologists in the state, it still takes 1 to 3 months for most referrals. In Brattleboro, they actually have to send out of state to New Hampshire or Massachusetts because the local ophthalmologist there doesn't perform many of the procedures in the bill. And I also have a chart of patients from Dr. Phillips' office, which is showing how long it took for he and his colleagues' patients to get treated once he referred them. And we'll make sure that this gets submitted as testimony as well. These patients agreed to share their names because they were so frustrated with the process. And if we think that's bad now, the 2024 workforce projections from the American Academy of Ophthalmology shows that there will be a shortage of ophthalmologists over the next 10 years by about 12%, and demand will be increasing by about 24%, and that's just not a great combination. As Dr. Lighthizer mentioned, SLT is becoming the first-line treatment for glaucoma. This is the study that will show you a little bit more about that. Optometrists are the physicians treating this disease now, first line with drops before sending for surgeries. Studies have shown that compliance with drops can be very difficult. My colleague was just telling me yesterday, he had a patient that had been lost to follow-up, that had been treated for drops on glaucoma, stopped using the drops, stopped coming in for follow-ups for 5 years, came back in recently, was almost nearly blind in one eye. And I believe that if this patient had SLT, which does not require drops daily unless it's more advanced and then they need less drops often, that I don't think that the vision would have been so severely affected or impacted. And if SLT continues to become the first-line treatment for glaucoma, we have a problem because there's no way ophthalmology can handle seeing all these patients in a timely manner for this quick laser procedure that's done in the office. If optometrists are the primary eye care providers for glaucoma, which we are, we have to be able to use all the tools at our discretion for first-line treatment. We believe passing this bill, especially being the first in the Northeast to do so, will help Vermont meet this impending surge in demand by strengthening our workforce. One of the first questions fourth-year students ask us when considering where to practice is, what is the scope in your state? These new optometrists do not want to be limited in what they can do based on where they live. They want to be caring for their patients with the skills and tools that they were trained to use. With hope that by increasing the scope to this degree, these new grads and other highly trained optometrists will want to come to work, helping to fill the gaps in coverage we have or will have as some retire. If optometrists are able to work to their full training, it will save the ophthalmologist chair time for more complex needs, such as cataract surgery and macular degeneration injections, things like that, which are outside of this scope that we're asking for. This bill is about working as a team to help deliver the best eye care possible to Vermonters. Given the licensing requirements in the bill and the rulemaking process, it will take a while to get this advanced license up and running. Passing X64 now will ensure that there will be time for this bill to be implemented thoughtfully and safely. As more states expand their optometric scope, Vermont might become a less desirable place to practice. Our state already has an uphill battle recruiting providers since the tax burden and cost of living is so steep here. We don't need more barriers like a limited scope keeping these skilled optometrists away. Let's be proactive and lead the way in New England by modernizing optometric care so that we can continue to attract highly qualified optometrists. Our population is aging, their eye care demands are increasing. We must make sure Vermont is in a position to continue to provide excellent eye care now and into the future. Lastly, OPR supports this bill after months of exhaustive research with all stakeholders. It contains high standards for doctors seeking the specialty license, including extra training, board exams, preceptorship, proctor procedures, and adverse event reporting. It also requires more continuing education to renew this license than the standard one, ensuring continued competency in these skills, effectively making this bill one of the most stringent in the country, as Deputy Secretary Hibbert mentioned yesterday. Additionally, the Oliver Wyman report shows that allowing providers to practice to the full extent of their education and training reduces healthcare costs and improves access. That is what S64 is all about. Instead of being the 49th state, like we were for allowing optometrists to treat glaucoma and the beginning of the eye wars, please help us join the other 16 states that now have laser authority and become one of the first in the Northeast to fully expand the scope by voting yes on this bill. I really appreciate your time. Thank you.
questions for the guest? I had first hand was Rep. Waters Evans a while ago, and then I got Rep. Stack.
So this is, I'm struggling with this. And what you said about, so it's already difficult to get, an appointment with an optometrist, just to get a routine eye exam. It takes like a few months. My concern is, I know it would improve access to certain procedures for people, especially in rural areas. Like, I understand that like the far drive and it's an issue, and I understand that. But my question is, if you can do a routine eye exam and make X amount of dollars, or you can take the same time out of your day to do some kind of a procedure that costs 3 times X amount of dollars. As a business person, I don't understand why you would choose to do a regular eye exam, let's say, or like a routine appointment. And I worry that it would actually make wait times longer for those things for people who need that regular checkup, or like, you know, you have to go get your prescription renewed every year for your contacts. And I just had to call yesterday, I think, and I got an appointment for August. And it's May. So can you explain to me how adding appointments to the schedule of people who are already booking like several months out is going to help access in general for people? Like, I understand that it improves access for specific things, but general care seems like it would be more, it would add to the weight.
So there's two things. One, not every patient needs these procedures done. So that's one thing. And a lot of times doctors will, you know, stack these type of procedures. Like you heard Dr. Porto yesterday, how she had a surgical morning. So you just kind of go back to back to back to back. And it doesn't take up like as much of a slot necessarily as you think this kind of visit would. Not every optometrist is going to do it, but it does make us more pleasing, I think, to newer grads that maybe they don't want to do all of the procedures on the bill, but they want to maybe be able to at some point, or, you know, just maybe they want to focus on just the glaucoma part or what have you. It just gets them into Vermont. It makes us more attractive. And when I went to the optometry national meeting last year, Vermont had a little booth in the States, you know, for all the 4th-year students to come around and ask questions. And all I heard was, what's the scope in your state? What's the scope in your state? Like, that's on their mind. They're thinking about that. And I know when I graduated, I did not want to go to a state that did not allow me to do what I was just trained and ready to do. So I really looked at that. And I think that knowing that we have gaps already, as you've noticed, and we have optometrists that are retiring soon, I think making us as attractive as possible would be really helpful.
Redstone.
Okay. I just keep asking questions about educational requirements because from my understanding, not all optometry students are receiving the same level of education or hands-on training in laser procedures and surgery. I know that all OD programs teach ocular disease and pharmacology, clinical management, stuff like that. But what I've heard is that training in lasers and surgical procedures varies quite significantly by school and state scope of practice laws. So I know my alma mater of UAB, their school of optometry lists, if you look on their website, laser and surgical procedure courses in their curricula for things that we're discussing, like GAG, SLT, LPI, stuff like that. But I just wondered if you could speak to kind of like parsing out how many programs actually teach hands-on training in that, not lectures, theory, didactic training, but hands-on. Because we keep hearing that students are trained, but I'm seeing that not every student is. It depends on the school. Could you speak to that?
Sure. So I haven't traveled around to all the schools, so I can't speak, you know, with my eyes seeing what they're doing. But from my understanding, from speaking to a lot of experts, is that They are teaching as hands-on as they can, as their scope allows. I think some of the states, as Dr. Feist mentioned yesterday, they have some ophthalmologists on staff, so the students are able to, you know, get a little bit more. I don't know what that looks like because I wasn't there, but to dive in a little bit deeper than just using model eyes. And as Dr. Feist and well, mostly Dr. Feist, and I think maybe even Dr. Porto had mentioned it, that these students, if they are interested in these procedures, they can seek during their 4th year when they have electives, their externship, they can seek to go to externships in states where this is allowed so that they can get more hands-on training than what was provided at the school. And this, you know, all students get this foundational training in school. It's up to that particular practitioner that wants to go and actually do it in practice. And so this would allow for those students and those graduates that want to do the next level to be able to do that in Vermont.
Sorry, I've asked this question a lot and everyone is kind of struggling to answer me. So I'm wondering if would the ASCO, you're accrediting,
The ACO.
the ones who accredit
Yeah.
ASCO, the ones who accredit
that's
optometry schools. Yeah, would they be somebody who could shed light on this?
So Dr.
I just think it's
Feist-
really important because there are years put in here of like students who are or optometrists who graduated after 2019 and whatnot. But what I'm hearing is that like even if you graduated after 2019, it still doesn't assure me that they've had hands-on training in these procedures. Like they may have been doing a fellowship or coursework or whatever the correct terminology is in a state that allows them to do these procedures, but they may not have. So I just want to could you point me in the right direction?
Sure. So Dr. Feist is the president of the ASCO. So I think she did cover a lot of what they get, at least in the school. And I think that when OPR did their studies and research, they felt the same as you, that it, you know, as much as all the schools are teaching it, not everyone is getting some hands-on training. I will tell you, we get a ton of hands-on training in, you know, a lot of foundational skills that are in this bill. We remove punctal, we put in punctal plugs, we remove foreign bodies. We do gonioscopy, which is using a little lens like you use during the laser on patients' eyes. We deal with squeamish patients from, you know, little kids up to adults that have never had an eye exam and don't know what to expect, you know, when they come in and they're 55 or 60, you know, or someone that just got a little piece of metal in their eye and have never seen an eye exam room before either. So I feel like our training is very foundational for this. OPR agrees that all the schools are training us, you know, as much as they can based on their state laws as it stands today. And to make sure that doctors in Vermont can do these procedures, they put in the preceptorship, they put in the proctored procedures and the extra board exams that are not required in many of the states that have already passed the scope, making this really the most stringent bill out there. And so in Vermont, I feel like you can rest assured that these doctors are going to be very well trained and ready to perform these procedures. No.
No.
Thinking
Thinking, yes,
with my hands.
she's charged here.
Yeah, I know.
Animated person.
No.
Rep Pistol?
I'd just like to add that, throughout my life, when I've had to have procedures done, one of the first things I say to a doctor is, how often have you done this? How many have you done? What are your complications? Are you comfortable? I mean, those are the questions that the patient should be asking. I don't think anybody, I would hope nobody would just go to a doctor thinking they're gonna get laser surgery and the doctor had never done laser surgery before. But I think that as a patient, you would ask, how often have you done this? Are you comfortable? Is this your specialty? Type of question. So really, some of this has to go to the patient responsibility as well, and not I mean, any doctor, any profession, any kind of specialty, you wouldn't go to hand doctor. I mean, like some of those pictures that they were showing yesterday, I mean, like, why would you go to an eye doctor? That's definitely a skin problem. To a dermatologist. I mean, that was just, come on, as a person who has no medical background, I mean, why would you go to an eye doctor for that? So I just think that a lot of this is patient responsibility and knowledge as well, or lack thereof.
Oh, it's situational awareness.
Yes.
Yes. There you go.
Yes, I have a question about these procedures that seem to be the most controversial. If they are in the moment that a patient has to make a decision sitting in the doctor's chair that, yes, I need to have this done now, or if it's a process that they can weigh the options of how they're going to get the problem taken care of.
As Dr. McNally mentioned yesterday, most of these procedures won't be done on the same day. You know, there are small like discrepancies, like if a patient came in with a conjunctival cyst, if there's time in the schedule and it allows like that, you know, if that was a reason they were there, it was bothering them every time they blinked, then that might be able to be done that day or things like that. You know, but most of the time, these procedures are, you know, we see you, we think you need this, these are the risks and the benefits, and let's schedule you when we can. And
That's really helpful for me, having had to have had emergency eye surgery. So if a patient is in a doctor's office, they have the time with the doctor to ask the questions, ask where they would have these procedures done, what the options are for them, and they can make a decision then, barring access problems if there's no other doctor who's available within driving distance or during the time frame that they need to have it taken care of. So that makes me feel a little more comfortable that these are not emergency situations where a patient has to decide that minute whether they are going to be treated by this particular doctor or not. They do have a choice.
you know, going back to the eyelid laceration, you know, if a patient comes in with one in Northeast Kingdom, right? In order to get to an ophthalmologist that can deal with it, it would be nice if one of the optometrists up there was able to do some of these things and just help to, you know, ensure that it's not going to get infected, or, you know, if they can help, you know, having these skills is really great.
It would almost feel to me, having been in an emergency situation, that I would go to the emergency department rather than an optometrist if I needed my eyelid sewn. I assume eyelids bleed like anything else that's ripped or torn. So I probably would head to the emergency department and they would refer me to whoever needs to do the procedure. So, you know, in terms of something that's emergent like that, it would feel like that wouldn't be a situation that would happen very often, because honestly, in the Northeast Kingdom, how many optometrists are going to have openings when you rip your eyelid open?
Those are emergencies, and optometrists take emergencies every day.
I think that this.
I'm not saying I would be the one doing it, but.
Now I'm just thinking of the number, or the lack of the number, the shortage of optometrists. They may not have openings in their schedules that they keep for emergency situations.
We make room for those type of things. If a patient calls with they just got a foreign body in their eye at work, come on in. Our office does that, and I guarantee almost every optometrist office does that, and ophthalmologist.
And you practice where?
In Rutland.
That's what I thought. So I feel like Northern Vermont is a little bit different animal than that, and people react more by going to an emergency department if they have something. I don't think they're going to choose to go to an optometrist right off, but I could be wrong.
Well, some of these procedures are really more routine treatments.
That's what I was getting at. So those are the things that we'll have time to think about, you know, okay, the optometrist doesn't have an opening until tomorrow morning at 10 o'clock. I can wait for that and see what they say about it, rather than something where they're really in need of care immediately. Thank you.
Any other questions for this stage of the game? Seeing no hands? All right, thank you very kindly for the testimony of the time. All right, committee, we're gonna take a 8 minute, no, we got a break till 11:30. And we are gonna do an introduction and a walkthrough on the Williston charter change. We don't have counsel for that, so we're gonna sponsor the bill and the town manager of Williston. So take this time to just read through the language real quick. Seems to be Worcester focused and reappraisal focused. So, oh, yeah, it's reps down.
I just wanted to follow up and we don't have to answer this now, but S64 does speak about eyelid lacerations, but ones that are not larger than 2.5 centimeters, not deeper than the orbicularis muscle and not involving the eyelid margin or lacrimal drainage structures. But I'm just pointing that out for patients. I don't think they're going to be measuring their eyelid during that time. So Rep Hango's situation may be something that we do want to dig a little bit more into, because this bill does talk about expanding OD scope to handle certain types of lacerations
Well, I think in
on your
that
eyelid.
case, thanks for bringing that up. I think in that case, my point is people will probably go to the emergency department to get something like that handled. At least that's my experience with folks in the Northeast Kingdom and Northwestern Vermont on the border.
And I hear what you're saying. I'm just saying in the bill that it does talk about eyelid lacerations and expanding the scope of ODs to handle certain ones. So I know personal preference is always something, you know, that's a patient's right, but I do just want to highlight that this bill does talk about eyelid lacerations in particular. So again, not something I think we should dig into right now. I don't want to belabor this and whatnot, but for further conversation later.
Yeah, I think that's a valid question for an optometrist. Like, do you actually anticipate having to measure the laceration when the patient comes in the office and then send them somewhere else if it's too big of a job to fix? That is a concern, yes. And we have an answer from the gallery.
Okay, and I got two from the gallery, so we'll start left and then we'll go right. Please re-identify yourself for the record.
Tina Geisha. Honestly, if an optometrist doesn't feel comfortable with the length of the laceration or depth, they're not gonna do it. And they're going to say, you should go see the ophthalmologist. I still think it would be better if we could start telling patients, go see your eye doctor first, not the ER. Because when you go to the ER, it costs so much more. And if an optometrist does not feel like they can handle it, they will refer them to an ophthalmologist right away. And if they can handle it, even better. And I think that's what this bill is really about. It's about, you know, we are the primary eye care providers in the state. And we will see emergency patients every day.
Further comment, Madam Deputy?
Yes, for the record, Lauren Hibbert, Deputy Secretary of State. I just want to tell this committee, if an optometrist were to do a suture on a length or depth that was greater than this bill, they would be charged with unprofessional conduct. I think they will be very mindful and stay within the constraints of what is written in the bill.
So I just want to say that with regards to the emergency department comment, I do understand the cost of it, but if I have a feeling that I'm going to be shuttled from one place to the other, I think that would be the first place I would go and feel most comfortable going. But that's just me.
And Representative Stone, is that a fresh hand or a legacy hand?
No, it's a legacy hand. I had a feeling that was going to be a hot button issue, but I'm just bringing us back to the language on the page when we bring up these topics, just reflecting that it is language in the bill. So stuff for us to be thinking about.
Any other questions or comment from the table before we hit pause till 11:30?